Thank you very much for this kind introduction. Not really true. No, I'm just having the honor to talk about seasoned women today, about this appropriate use of menopause hormone therapy. We don't call it replacement anymore. We call it menopausal hormone therapy. And I have no conflicts of interest in regard to this presentation. I go back. So we will talk about the history of menopause first, then I give you some special considerations for women living with HIV. We talk about symptoms and the indication when you decide for treatment, and I will also talk about what we have for treatment and drug-drug interactions with our antiretrovirals. So first of all, the word menopause comes from the Greek word. This is mens for month and pause is for cessation. So actually, of course, you all know that it's when the menstrual period stops. So the menopause starts when the last bleeding happens and there's 12 months without bleeding. And historical medicine didn't use the right language, as we learned yesterday. So women were deformed males, and menopause was a deficiency disease. And treatment cures you can see on the picture. I never tried that, but it's leeches on the genitalia, cold water, arsenic, and you can see some parallels to the nowadays playing golf. So 1942, there was the first estrogen product marketed under the name Premarin. And now listen to this, how it was advertised. A woman is likely to feel that her charm is gone and the golden days of her womanhood are irrevocably past. But Premarin helps. So who would not want to take Premarin? We're really a success, and husbands like Premarin too, as the hormone pills make a woman pleasant to live with once again. So this is, could you do that today? I think it's wonderful, very charming for seasoned women. So we know, and this is a picture from the Swiss HIV cohort I'm working with, we know that a high proportion of women living with HIV are of menopausal age, and we can see that in the Swiss cohort that the proportion tripled from 11% in 2010 to 36% 2018, and we know also that 1/3 of our women are between 39 and 49 years old, so there will be transitioning through menopause in the next 10 years. So we have to get prepared. So what is menopause? Is it a disease or is it just transition? So first of all, it's a long-term hormone deficiency affecting all women. So it's a deficiency of estradiol, testosterone, and progesterone. And of course, it lasts over many years until death. It sounds really dramatic. But what we want to talk today is really about quality of life and menopause being associated with health risks. So if we look at women living with HIV, we have considerations in terms of their health. We talked about it today and yesterday. Bone mineral density, a huge issue. Cardiovascular risk, we learned about this a lot today. Breast cancer risk, we forgot about this so far, to talk about, cognitive impairment, and emotional and mood issues. And when it comes to symptoms, you know that there's the hot flushes here on the first point, weight gain, but also loss of sleep, and this makes everything more complicated, vaginal dryness, and sexual dissatisfaction. Actually, this sounds very dramatic, but if we think about menopause, we also have to think about when it happens, we need to think about contraception. And this is a part of our sexual health talk. So if menopause occurs over 50 years, you do contraception 1 year after menopause because there might be an ovulation. And if it occurs before 50 years, we recommend contraception 2 years. But you can do it combined with hormonal replacement. The problem is that if you see women in your clinic, disentangling is really not an easy task because they have to face the question, are my symptoms related to menopause? Is it aging? Is it HIV treatment or depression? Is it something else? And if I see women coming in and they are diagnosed suddenly with cessation of their period with depression, it has to be really talked about other symptoms and menopause treatment and not only antidepressants. It would be easy if a blood test would be available, like if we could say, this is now menopause and I can explain your symptoms. But you can see in this curve that the hormones are really fluctuating from day to day. So if you measure estrogen in one day, it could be totally different. And this is what makes also the symptoms. And you can't do this. And it is even more complicated because the estrogen levels do not really relate to the symptoms. So there might be women, they have the same estrogen level in the blood, and they have absolute different symptoms, one very severe, the other none. So we do not recommend, like it was mentioned today, we want to have a clinical diagnosis, and we do not recommend to spend money for blood tests. And it's sometimes necessary to diagnose early menopause, or women who had a hysterectomy, or sometimes if the hormone dose does not really explain that the symptoms not getting better, we do hormone levels in the bloods. So if we can't use a good blood test, how do we evaluate then menopause and indication for treatment? You can see here the menopause rating scale. I really recommend that to have in your practice, because then women can just make a cross if those symptoms mentioned all on this nice picture are mild, severe, and you can also see after commencing treatment if she feels better and which symptoms are still the same. And here we talk about hot flushes, everybody knows that. We talk about joint pains. This is less known in women, that this general joint pain is really a menopause symptom. Brain fog, we all know that from ourselves. We know the vaginal dryness, of course, this is a symptom I will talk about later. And irritability, and all those mood issues. When women say they made a career, they are really strong, they're supposed to make decisions, and they come in the clinic and they say, if I have to take a decision in my job, I start to cry, I can't do it, I feel like I'm a different person. This is what the story, and then you have to ask more, and then here it is, really in the middle of menopause. And we don't want to talk only about symptoms, but we want to talk about reduced quality of life. And this means women are avoiding social meetings, they can't go to work, and you have to find out what's the main reason for women thinking that they have this reduced quality of life. And this is really, really what we treat. So if we come to hot flushes, this is a picture showing you that it's not a moment now and then. Hot flushes can last over 7 years, and with early menopause, they can last over 10 years. And what is sometimes forgotten is that women over 70 years have in 10% still vasomotor symptoms. And they can really reduce quality of life, and especially they can also disturb your sleep at night. So we heard a lot about cardiovascular disease, so I decided only to tell you this, or to show you this study, that severe vasomotor symptoms, they are associated with having cardiovascular events. And this is shown in the red curve. You can see the more vasomotor symptoms, the more events, cardiovascular events. And isn't that interesting, because we know it is stressful, maybe high blood pressure, and all this together. And we also heard today that it's not yet an indication for hormone treatment as a primary prevention for cardiovascular disease, but there's more and more data to show that treatment is good because we improve quality of life and well-being. And in terms of cardiovascular disease, I really want to say here that we have the opportunity in our menopause clinic to talk about the essential life's aid, and like nutrition, quit smoking, get healthy sleep, manage weight. We heard that today. It's not only the weight, it's just getting some more movement in your daily life and manage your blood pressures, of course. So this is a complicated topic, because why is this low estrogen associated with all this brain fog, mood issues, depressive symptoms, anxiety, irritability? And what we know is that low estrogen has an effect on the nerves in the amygdala and hippocampus and frontal brain. And we see women, and I want to show you one study with a Swiss HIV cohort. So we were asking ourselves what happens in the transition through menopause, and we found that the rates of depression and psychiatric care increased in the perimenopause, that can be 5 years, 8 years before menopause, but it did not result in viral blips, it did not result in low viremia or viral failure. So this was good news because women were motivated, but I think if women have a low quality of life, it might really affect adherence. The bone loss is a really, really important topic, and you see on the slide that women living with HIV in the menopause have up to 9% lower bone mineral density in the lumbar spine and total hip and radius. And of course, we heard about aging and falls, and such a fracture is avoidable if we start to explain that vitamin D and calcium and doing some physical exercise is the first prevention, and that women are aware, and that we offer a bone mineral density measurement. We found in our Swiss HIV cohort study that only 1/4 of women had this bone mineral density measurement, and it should be more. So this is a very important message, that age at menopause matters if you decide for treatment or not. Because the physiological menopause, we would say it's around 50, and you know there's conflicting results from studies if women living with HIV go through menopause earlier. There's different results from different studies, but late menopause is after 55. But very important, early menopause or premature ovarian insufficiency, POI, before 40 years, this is a clear indication to put those women on menopausal hormone treatment due to so many benefits for their health. So we call this the window of opportunity, that we have to be aware of symptoms in time, and we start MHT within 10 years after the last menstrual period, and it would be best to start before 60 years. And this is also an important message for us as clinicians, to ask for menopausal symptoms and to start treatment in this window of opportunity. Topical treatment with estrogen is not considered as menopausal hormone treatment because it's only local, it's not going to the system, but it's a must-do in my opinion. It's really, you have to offer that. Women will come back and they say, "Thank you, doctor, I never will stop this." It improves the tissue moisture level, elasticity. It's these itching, burning symptoms, they nearly disappear, and no pain during sexual intercourse or less. Reduced urinary tract infections. There's also some slightly support in some forms of incontinence. And it's, as I said, it's minimally absorbed, so you don't have to give progesterone with it. And the low dose can be used with a history of breast cancer or with a risk of breast cancer, and it can be used lifelong. So the different forms, if you use tablets or cream or gel, is an individual decision, and there's different women deciding for different application forms. One word to herbal drugs, because I learned from my women that sometimes there's a cultural background that they say, "Oh, my grandmother, my mother has taken this herbal drug and this helps me." And there's nothing to say about it if somebody's happy with that, and there's different studies of effectiveness of those herbals. But don't think that herbals do not have drug-drug interaction with antiretroviral therapy. So you can check the Liverpool drug-drug interaction website, even for herbals, to see if there's an interaction. Otherwise, I think it's the first step we're doing. Sometimes we try herbals. And then it comes to the hormone treatment. And this is really, really a slide to show you that the first step is to aim symptom reduction, to improve quality of life. There's a clear cardiovascular benefit, there's a bone benefit, reduction of risk for diabetes type 2, and there's a reduction of all-cause mortality. I also put on this slide the contraindications, and if a woman has increased vaginal bleeding, unclear, of course you have to first see if there's, you do a hysteroscopy and see if everything is okay. Of course, if she has an estrogen-sensitive cancer, if she doesn't have a mammography yet, you should not start. You should get your checklist done, and then you can start her on the therapy. So the first line, and we know more and more that this is really the best, is transdermal estrogen. Normally, we start with a middle dose, and we ask women to get symptom adapted. So they take this transdermal estrogen. If the hot flushes disappear, wonderful. Otherwise, they increase the dose. And if they have kind of mastodynia, that they feel there's too much estrogen, so they reduce the dose. There's no thromboembolic risk, and some women don't know that, so you can really, this is the best thing to start with. And as I said, as soon as you give transdermal estrogen for the protection of the endometrium of the uterus, you have to give also progesterone. And there's two options. Either you give it sequential for 12 days per month in women perimenopausal or early menopause, or you give it continuous. But it's very important that as long as the uterus is there, you will induce endometrial cancer if you give only estrogen. So this is just to know, but it's actually the best to give the body identical progesterone in the evening. That makes also a bit tired, so women are very happy with that. So we come to drug-drug interactions. And of course, you know the Liverpool database, and this is such an important tool for us because we have so many antiretroviral drugs and interactions with hormones. And if it comes to menopausal hormone therapy, I just want to say here that most of the drugs have no interaction at all, and some older NNRTIs slightly might decrease hormone levels. But what does it mean? We have to increase our application. So it's not a worrying really to reduce the symptoms. And you can check that website because it's always updated. So a huge topic is libido. So libido loss, especially that women say, what can I do? And unfortunately, there's no such pill as shown on the slide. But the first thing is really, and the most important, to start the conversation. Of course, we gynecologists, we focus on cervical cancer screening, and it takes time to talk about sex, because when you talk about sexual well-being, you're in the middle of a woman's life, and it might take some time, but it's worth it. Because the first question would be, how is your sex life? And you don't forget the U equals U discussion. Sometimes I invite the partner also to discuss, and the first steps to improve this sexual well-being is offer vaginal estrogen, I showed on the slide, moisturizers, and psychosexual support. And the next slide I will show you about testosterone, because it was, at least in Switzerland, in the media and newspapers, being prescribed off-label to increase libido as a transdermal application. I read this North American Menopause Society practice pearl about testosterone, and I really liked it. It was published last year because it says that it's an evidence-based therapy for hypoactive sexual desire disorder, and you use it transdermal. You put it on your calf, and it's 300 micrograms a day. Of course, you will start with a monitoring of the testosterone levels 3 and 6 weeks after start, and then 6 monthly. I have now more and more women taking this, and they are very happy. There's very rarely some side effects, and as I said, you have to discuss the off-label use, and you have to be sure that you address all the other issues associated with this sexual health that they want to improve. It's not only a cream that can help. The fear of weight gain, we talked about this a lot, and this is the group from Bern who it's not in women living with HIV, but I found those publications really interesting because they say that resting energy expenditure is the largest component of total energy expenditure. It's not only eating and doing sports, and they did a systematic review of 10 studies, and they found that estrogen administration increased the resting energy expenditure to 220 kilocalories. So this is, of course, you might say, okay, this is only 3 bananas, but it's an increase. And there's other studies I read that during ovulation, women have a higher energy expenditure. So when the estrogen levels are higher, This is described in other studies. And you might think, okay, but what does it mean? I also think it's the well-being, because you are more motivated maybe if you feel better, if you stop sweating, if you stop feeling depressed. So it can be a mix. So the fear of breast cancer, another fear. So when I say, do you want to start with hormones? No, 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 no. This causes breast cancer. But to be honest, you can see here on the slide that menopausal hormone therapy for 2 years increases your risk of breast cancer per 1,000 women between 50 and 70 years old. About 2 cases, for 5 years around 4 cases, additional cases. In blue, that's the background. So we have really a lot of breast cancer. Every 9 women in Switzerland has breast cancer. But look at alcohol, it's plus 72 cases. Then this is this is no physical activity, so just sitting like we do today, 72. Weight gain or BMI over 30, and this is even more, 90 cases, and then cigarette smoking. So I just want to mention here that I work with that table sometimes just to tell women, of course, you have a small increased risk of breast cancer. But if you compare it to having 2 units of alcohol per day or more, if you compare it to cigarette smoking, it's really less, and you will improve your quality of life. And if it comes to breast cancer risk, I'm very happy to say that there's a new drug on the market approved by the FDA, fezolinetant, and this is the first neurokinin 3 receptor antagonist, so no hormones, but it is only to treat hot flushes. Don't think it will treat other symptoms. So if women, for example, have a history of breast cancer or they have a family risk of breast cancer, this is a very promising drug to reduce hot flushes because it's blocking the activities of the NK3 receptor in the brain and is effective in the studies. I will show it to you in the next slide. After 12 weeks in 60%. And of course, you see the placebo has still 30%, but this drug seems to work quite well, and unfortunately, it's not paid by the insurances yet, but we're waiting for this approval in the summer of this year. What you have to do before you start this drug, you have to do the liver enzymes and be sure that there's a normal function. So I show you here that we already got data from the Liverpool database. We know how fezolinetant is metabolized, so we can say that we do not expect any interactions with antiretrovirals. And this is very good news, but we have no data on women living with HIV. So I want to close with a paper published by the Working Group for Menopause of the Women Against Virus in Europe group. It's a group in IACS. And actually, this was just a paper to review all the guidelines for women living with HIV to see if menopause is addressed. And first of all, we found that diagnosis of menopause there's no good guidance in the HIV guidelines. And as well, sometimes there's no good tool to really ask for symptoms. So the symptoms here, when should you start to ask for symptoms? It's not clear. And is the menopause rating scale, is it really used for women living with HIV, for Black women, for all cultural backgrounds? And the last thing is that we have very little guidance on treatment for women living with HIV. If it comes to when to start, the risk-benefit, and as well, just to tell women that we have in Switzerland only 10% of women living with HIV on MHD, so you can't really say that they should do peer-to-peer education because we didn't offer it because we were afraid of using it. So as a summary, I have to say that women living with HIV will go 100% through menopause, and the majority of them will have symptoms. So please look at this rating scale or ask for symptoms, and then ask for comorbidities in the next step to decide for treatment. We know that MHD is able to improve quality of life, and we have the cardiovascular bone benefit and much more. It's not contraindicated in women living with HIV. This is a really important message. So we need better guidance and from our community as well. And the drug-drug interactions are really, that is the main fear of the doctors, and they are not there. So they will not compromise MHD effects. So our aim would be to have clearer guidelines, to share experiences, on the one hand for the assessment of menopause, but also for treatment for women living with HIV. And menopausal women are powerful. You can see 4 days ago, 2,000 seasoned, I don't say elderly, Swiss women won a landmark climate case at the Human Rights Court in Brussels, and they are all over 64 years old, and I would say they take MHT. So thank you for your attention, and those are my acknowledgements, and the picture is because I did my HIV treatment in Ireland, as you can maybe hear sometimes, and I felt like on the picture when I came. Thank you.